Hi everyone, my name is Sahdev Baweja. Thank you for joining Ask the Neurologist podcast series. Today I have the pleasure of interviewing Dr. Gurmeen Kaur. She's a vascular and neurointerventionist. Dr. Kaur, thank you for jumping on today.
Thank you so much.
So our first question for you is, can you tell us a little bit about yourself and why you chose to do the field you did?
Yes. So, I always wanted to do neurosciences, even when I was a little kid. The last sort of memory of my father is he was sitting on the edge of the bed with like projectile vomiting when I was 4, and they kind of he had a tumor and kind of spiked my interest. Back then I was a little kid at that time, and then I was in college when I lost my best friend to status epilepticus. And at that point, by then I had read a lot about neurology or, brain related diseases, and I was kind of committed to going into neurosciences. What I did not know is sort of what subspecialty of neurology it would be. And that actually took me a pretty long time to explore. In medical school, I was kind of interested in stroke, and then I, had the privilege of seeing a few aneurysm coiling cases. I thought that was really cool. But then sort of during college, sort of after, um, before applying for residencies, um, I explored a lot of other neurology subdivisions, including epilepsy and even functional neurosciences, functional MRIs, by working in a lab, and then started residency. And then in my first year of residency, I realized I still, my first love was still stroke and intervention. And timeline wise, 2015 was sort of my first neurology year after the categorical medicine year. And that was the point where Mr. Clean and all the newest stroke trials had come out, showing, the efficacy of intervention in stroke. And that was sort of, the point where I decided that's the path that I want to take.
It's a really interesting story, and I think our experiences early on definitely shape what we do later in life. Was there ever other field in medicine you considered?
I actually very strongly considered, I thought I would have liked HEMONC when I was still doing my electives. But then when I actually did HEMONC, I realized I needed a slightly more faster paced sort of setting. So I sort of, thought pulm crit for a long time, even in my prelim year of, medicine before starting neurology. I was still sort of thinking about pulm crit, mostly because I liked the setting. I liked the fast-paced inpatient setting, which is very similar to sort of neuro ICU or running codes, etc. So that was sort of what I enjoyed the most in my medicine year, and sort of thought about it a little bit, but then eventually ended up doing neurology.
Okay, so can you tell us what conditions you treat?
Yes, so I'm a vascular neurologist and a neurointerventionalist. So I do a little bit of stroke as well as neurointervention built into the same job profile. And what that entails is, in stroke service, vascular neurology service, I see everybody with ischemic and hemorrhagic strokes, venous sinus thrombosis, arteriovenous malformations, arteriovenous fistulas, um, spinal cord infarcts. Those are sort of the patients I see primarily on the vascular neurology service. On neurointervention, and there's obviously overlap between the two, I do stroke thrombectomies for the ischemic strokes. For the hemorrhagic strokes, depending on if it's a subarachnoid, then they would do coiling. Um, and if it's an AV fistula or AVM, then embolization. Some head and neck tumor embolization, nosebleeds, central retinal artery occlusion, intraarterial therapies, um, elective spinal, embolizations, elective aneurysmal repairs. That would sort of be the MMA embolizations or middle meningeal embolizations for subdural hematomas, which is another kind of hemorrhagic stroke. So essentially, overall, bleeding disorders of the head and neck, hemorrhagic strokes, and ischemic strokes.
That sounds really cool and it encompasses a lot of things. Could you explain your path to getting here, like what residency or fellowships it requires, and how how it would be different for someone who's approaching this from a neurosurgical standpoint?
So from after finishing, so neurology residency is obviously a 4-year program. The first year is medicine, and then this 3 years of neurology. And then after that, to get to neurointervention fellowship, which at most places falls under the sort of neurosurgery division, but is open to neurology, radiology, as well as neurosurgery selective candidates. So to get to that, you have to sort of do an intermediate fellowship, which can be vascular neurology or neurocritical care. I personally did vascular neurology fellowship, which was 1 year, and then I did a neurointervention on endovascular neurosurgery fellowship, which is a 2-year fellowship following that. I could have also done neurocritical care or neurointervention. For people going into neurointervention from the radiology background, they need to do a diagnostic neuroradiology fellowship prior. Neurosurgery, which is a 7-year residency, can directly go on to do an endovascular fellowship, but the endovascular fellowship or neurointerventional fellowship per se is 2 years, irrespective of what domain you're coming from. So essentially, that's the common grounds. Just the pathways to get to neurointervention fellowship is different. Sometimes through the neurosurgery pathway, because of the 1-year research built in like PGY4, they can do, if the specific programs allow, they can incorporate 1 year of fellowship into the PGY4 and then graduate PGY7 and then do another second year of the intervention fellowship. All in all, you still have to spend 2 years doing the intervention fellowship alone.
Okay, and is there any differences when it comes to practicing between someone who's come from a neurosurgery background or radiology or neurology?
The learning curve is different starting out, because for a lot of radiology, they have done some time doing interventional radiology, mostly in residency, but they don't have the clinical context of actually seeing so many ischemic stroke patients or hemorrhagic stroke patients. So their most difficult learning part happens to be the clinical aspect, the clinical correlation part. With people from the neurology background, they have an extensive background or understanding of stroke etiology, management, etc. And what they don't have is as much hands-on skill unless they've done more elective time knowing that they're going into neurointervention fellowship. So the first 3 to 4 months can be challenging where you're still learning a lot of the skills that you don't have. Neurosurgery has the advantage that they are more comfortable starting out because they've done a lot of open surgery, but they also have the same challenges when it comes to patient selection or understanding natural history of strokes. And that's sort of the learning curve for them in the initial phase. Eventually, by 6 months, you can not tell what background the person came in from. Everybody's equally comfortable doing it.
Okay, thank you. So since you cover stroke service, you cover obviously all interventional, what is a week or day in your life like?
There's a lot of variability. There are, stroke service. I usually, depending on how many stroke attendings are in a place, it's usually a week at a time. And that week, you're on call basically 24/7, receiving, depending on who the primary responder is, receiving phone calls / seeing in person stroke cores that are coming through the ER as well as all over the hospital. That's like one busy week. It's a lot of hours per day. And then usually I'm off service for 2 weeks after that. Neurointervention, again, depends on how you split up the schedule. We are 4 people splitting it up. So we end up doing 1 in 4 weeks, but we do a day at a time. So I think what I'm trying to get at is there's a lot of variability. Stroke call does not require me to come in overnight. Intervention call is obviously, depending on whatever's coming in, you have to be available to come in. But stroke call is a lot more phone calls and a lot more triaging than intervention call is.
So it seems like it's very variable, but would you say on average, is there an average number of hours a week you work or something like that, or is it just very dependent?
It's a wild guess, but I think at least 40 to 50, I would
Okay,
think per week. It's a totally wild guess though.
okay.
Because
And
every week is different. It depends if you have clinic or you're just on one service, or if you're on two services together, it can be sort of variable.
and I know you also do research, you also mentor students. So what's the work-life balance like for you as someone whose schedule can vary so much?
It's actually harder for the people I mentor than for me, because they have to track me down and sort of, make sure that you've experienced that. But it's if you're passionate about it, you'll make time, and you just expect that people who you're working with will understand if you're in the middle of a case, you're in the middle of a case, and we need to reschedule. Um, but in the off weeks, there is time to do research. Like, I do have a schedule that does allow me to build in research time. If I'm on intervention call, there is obviously the unpredictability in the schedule. But other than that, if I organize my day, I can sort of, incorporate time for doing research.
And also in general, more so, do you think you still are able to balance time with family and other things that you're interested in with such a variable schedule?
So, thankfully, that yes, the answer to that is yes. Um, but that's because at this point we are blessed that we have 4 stroke attendings and 4 intervention attendings. So the call does get split up. It depends on what kind of practice or what kind of system you're in. And that's sort of a decision that you have to sort of make early on while choosing academic versus private practice, or a model where you kind of have to lay the boundaries of how busy am I ready to be? How many weekends a month am I ready to not be with family and be working? And those are sort of, late fellowship, early attending decisions that you make based on your, family and sort of wants and needs.
Okay. Thank you so much for sharing that. So these are more general questions. What advice would you have for anyone who's aspiring to be a neurologist, neurointerventionalist?
Do not give up is one thing I would say. Even if because neurointervention is sort of now increasingly a very hard fellowship to get. Having said that, anybody who's really wanted to get into stroke and intervention and stayed true to their, wants and aims, I have seen them sort of get the fellowship they want and do really well. So don't give up would be the one thing I would say.
I
Keep
think
trying.
I think it's very good advice for everyone. What would you say is the biggest challenges facing someone in your career today?
Um, for me personally, jobs in academic settings are sort of saturated in especially busier areas, the tri-state area, obviously. Or if you talk about busier centers, there's a lot of people already established, and it's not that much of a turnover. And you can't keep adding people because the pool of the patients that you have is limited. So that's one big challenge. Having said that, you know, people have always found good jobs. So it's not like it's not possible to do. That's one of the bigger challenges I've faced starting out as a new attending, 2, 3 years ago. The other challenge sometimes with intervention and having families is the unpredictability. You can be out with your family and suddenly have to go in. So you have to have a backup plan for your kids, nanny slash somebody else to sort of take over for you, even if you go out anywhere on a call day. But that's something that and you can sort of build, we still have fun even when I'm on call, as a family. But we just need to plan a little bit more, and we take two cars instead of just the one car. So these are subtle things that you sort of have to learn how to adapt to.
Okay. What do you think, how do you think the field will change over the next 5, 10, 15 years?
I think with all the new stroke data coming in, especially with now with the late window trials and intervention opening up to patients with like even huge infarcts, the number of cases that we would have is drastically going to increase. So I think the future is actually very bright. It's a new field relatively as compared to, interventional cardiology, which has been there for probably a decade more, if not a little bit more than that. I think we are not at the prime of neurointervention yet, and I think the prime would be in the next couple of years.
And what do you think would change in that prime as opposed to how we do things now?
Outcomes for ischemic strokes. Right now,
Okay.
I think we give up if this stroke is very well established or huge or has minor subtle hemorrhage somewhere. I don't think very significant advances are going to be made in the hemorrhagic stroke field, because I think we're kind of at the point where we're already doing a great job. With ischemic strokes, I think our patient outcomes, 3-month outcomes, 6-month outcomes, will drastically improve over the next 5 years.
Okay. So we're at our last question, which we like to ask everyone, and is what is your favorite part of the CNS or brain and why?
My favorite part is the hippocampus, because it makes memories that you can hold on to forever.
That's a really good answer. Thank you so much for joining us today, Dr. Kaur. It was really insightful learning from you, and we appreciate your time.
Thank you so much.